Hi, and welcome to the latest episode of Real Nurse Stories. Today, I'm delighted to be able to interview Dr. Lorre Laws. Lorre is a nurse, an author, a professor, an educator, speaker, and an all-round high-vibe person with a warm heart and a fantastic sense of humour. She's a master storyteller and a Toastmasters award-winning public speaker. Her area of expertise is in nursing, healthcare, trauma, burnout, wellness, and spirituality. Lorre describes her mission as helping nurses and other professionals to recover from work-related traumatization and burnout using an evidence-based framework, integrated health strategies, and healing arts practice. So let's jump in whilst I interview Lorre, and I'm sure this is going to be a fascinating interview, so stay tuned. So hi, and welcome to Real Nurse Stories. Today I'm welcoming my podcast guest, Dr. Lorre Laws, who has a very interesting career story, and I really can't wait to interview. So first of all, welcome, Lorre, to Real Nurse Stories.
Thank you so much. We're all such real nurses in so many different ways. I love our profession that we can be and do so many different things, across our careers. And I'm just so happy to be here, and also am a nurse coach here in the States. So you and I share that as well.
We do indeed. So, Lorre, what I'd like to do, where I always start, is at the beginning, really. And I would like to invite you just to share a little bit about your nursing career and kind of what prompted you to go into nursing, if you wouldn't mind, and we can start there.
Oh my goodness. Well, that's quite a story, but I'll see if I can give the cliff notes, as I am, as they would say, a very mature woman. But my story, my entry into the profession has been largely a spiritual one. And um, it started at the age of 14 when I was looking, to do something besides babysitting to earn pocket money, as any 14-year-old wants the latest pair of jeans and to go to the theater with her friends and so forth. So I found myself cleaning resident restrooms at a local skilled nursing facility, an old folks home, a nursing home, many names it has taken over the ages. And I was captivated. I mean, not by the restrooms, but by the residents. And it was my first real exposure into people who were in the latter stages of the lifespan or struggling with a myriad of health conditions. And so I decided at the age of 15 to get my certified nursing assistant certificate, which is the earliest you can attain that credential here in the States. And so from the age of 15 until 18, I continued on at this skilled nursing facility and helping people transition at end of life. And before I could legally drive a car, before I could legally vote, this was what I was doing. And I really feel it formed what I call my healer's heart, my why for nursing, my why for so many of the things that I do. And so it was such an interesting way to start. And then I went off to university thinking I was going to continue down that path. And I worked for a couple more years at a teaching hospital in a med surg unit. And of course, no different than today. Here we are, half of a century, gasp, later. And, we're under-resourced and we're understaffed, as was the case then. And I had a bariatric patient that I was doing a transfer with and for, and we didn't have enough Hoyer lifts. There was only one Hoyer lift for the entire fourth floor, which had 4 wings. And so the patient started going, and I did everything I could to, make that a soft landing, but at the expense of herniating severely 3 of my discs in the lower back. And as I was recovering, and the healthcare team and my employer and my university advisors, everybody was agreed that the severity of this injury was such that I should not pursue this profession, the profession of nursing. And so 20-year-old me, 21, I think, by the time that decision was made, I heeded that counsel, not knowing any better or different, and went on to have a couple of other careers, one in business, and where I thrived, but my heart wasn't being nourished. I wasn't giving. I was good at my skill set, but there was something missing. And then I taught art for a good number of years, and that sort of helped me get reconnected into that more creative, spiritual place. And through a series of really unfortunate circumstances that I've come to know as divinely guided, at the age of 48, my life sort of went upside down. I had nearly died from a home that I was living in for 20 years that had toxic mold, and we didn't know it, and nobody knew it. And so I was misdiagnosed with every possible chronic condition one can imagine, and continued to get to the point where I couldn't even sit up in a chair. I couldn't even watch my children's, you say football games, right? We say soccer.
Yeah. Yeah.
I'd have to lay on the side of the field. And so they couldn't figure out what was wrong with me. And I had excellent medical care and went right to the top of UCLA Medical Center, academic medicine, chief of rheumatology, like every effort was being made on my behalf. And they said, well, we see there's something terribly wrong, but we don't know what it is. And this was back in the mid 2000s. And of course, the state of the science surrounding mold illness was not where it is today. And so devastated. I mean, I have 3 children, 3 school-age children at this point, and I'm really trying not to orphan them. was kind of my biggest thing. So I took to my car and my tent and left my children in the care of their father while I searched for a non-Western medical solution. I had to get really down to this like really at the bottom of the deepest, darkest pit of hope and despair. I had to visit that rock bottom place. And I just refused to accept that that there was no hope for me. I refused to accept that. And so I kind of came to this conclusion that, well, just because you can't help me, Western medicine, doesn't mean that there aren't other ways of healing, and there aren't other health traditions that can't be helpful to me. And so I set off to started off. I thought, well, the first place I'm starting is with nature. With God. I'm a very spiritual person, and so with multiple ways of knowing and multiple abilities in those realms, that I took my solace and my guidance from those sources. And made a full recovery, just so we all know. Went on to be a part of a number of researchers, scientists, clinicians, and we have founded an international society for environmentally acquired illnesses, ICEIL. AI, which is we have a good number of practitioners and scholars in Australia. So for anybody out there who's affected, just know that we have put together the evidence base, and we do have the science now that wasn't available for me, and that was probably part of what I was supposed to be doing also.
Yeah. Yeah.
So all that to
Yeah.
say, my life was upside down. I had no job. I was ill. I was living out of my car and trying not to die. And of course, my marriage didn't survive that.
Mm.
And so at the age of 49, I was like, whew, I am starting over. And so I was really, really trying to figure out what my next step might be. I was now well enough to go back to school, not quite ready to work a full-time job, but I was well enough to go to school part-time. And so I thought for sure I was going to go be a hospice nurse. I started with a death doula, drawing on my very early years at the
Yeah.
bedside. And I needed something with more financial stability, as I was still had children that were being raised and needed to go to university and such. And so I went to nursing school thinking that I was going to be a hospice nurse, but that turned out to be my middle child, my eldest daughter. She's the hospice nurse, as it all worked out. So
Yeah.
I entered the profession, and I had a bachelor's degree in biological medical sciences. So I had a background, but it was 30 years old by this point. So
Yeah.
I decided to redo all of those science courses, and also to kind of see if the old gal still had game, to go to nursing school at 50 while you're in menopause is that's a big ask. And so as it turned out, I was
Yeah.
very much ready and I did very, very well. And I got to the end of my master's degree and was going to enter practice, and as a mature woman now, looking at, not much had changed. Not much
No.
had changed for nurses. What had changed is that we didn't have to wear all whites. What
Yeah.
had changed is that the patients could no longer smoke in their patient rooms. The staff couldn't smoke in the lounge, okay, and then the other thing that was that the nurses no longer, as was the case when I was coming up as a very young woman, we no longer had to avail our seats if a physician should happen to come by the nurses station while we were charting. We would immediately have to jump out of our seat, stop our charting, and for lack of a better word, pamper them.
Yeah.
And and so I saw that those things had changed, but the sort of paternalistic, second class, oppressive social structures
Mm.
were still in place where nurses were concerned.
Mm.
And now, but it was worse because now we have dangerous staffing ratios, many of us, in
Yeah.
our roles. We still don't have enough resources. And I was being asked to go take care of, as a new graduate nurse, up to 7 patients by myself.
It's scary, isn't
And,
it?
and
Scary
yeah,
thoughts.
it's really scary. And so I said no thank you to that.
Mm.
I mean, as a 20-year-old, I would not have said no thank you to that. I would have accepted it
Mm.
as the status quo and sucked it up. But I think that's part of the reason divinely guided, right, divine right order. I'm big on that. I have
Yeah.
full trust in that, I was my part of what I was supposed to do with my nursing career was to affect change. And
Yeah.
that meant that I needed to have a lot of life experience. And I had to have already been very, very successful in a
Mm.
business setting to have, so it just was like an
Yeah.
entering the practice. So I went on, I said, no, thank you. I can't. And I can't, I'm not, no. I need to help change this. Nothing has changed here in 50 years. It's like we got to try again. And so, well, it was 40 years at that point. And so I continued on and earned my PhD, and it came in nursing, and it came very clear that I was being guided to work outside of the healthcare system to affect change, because I wouldn't be able to do what I do if I were encumbered by it in practice. And so I finished my PhD in 2018, and then I did two postdoctorate fellowships in integrative health, and learned how to be a university professor. So I'm at a major university here in the United States, and we have the first ever Bachelor of Science in Nursing with an integrative health focus. And so I thought that was it. Oh, I thought that was it. I have arrived. This is what I'm supposed to be doing. And the ink was no more dry on my PhD piece of paper, my diploma. And then I was guided to start researching for burnout, and asking some big research questions, and I think this is also why my entry into the profession was so deferred and delayed, is because I wanted to know why in 40 years at that time, 4 decades, are we still talking about the same burnout narrative? And nothing has improved. And so I had some really big research questions around that. And so I started doing what any good nurse scientist does, which is what I do for my day job, right? Is I started really doing some deep dives into the evidence base. And I also, during that time, was teaching for the College of Social and Behavioral Sciences. So I have a background. So I was able, just because of the way that my life unfolded, I was able to go into other disciplines, non-nursing disciplines, looking for answers. And indeed, I went to, the sciences of neurophysiology and relational neuroscience. And there I started to see it, because it's not just burnout. It's not.
No.
It's nurse-specific traumatization.
I
And
think it's fascinating, Lorre, that you talk very passionately about this, and I think I often talk about your why. So why in terms of leadership, why do you want to be a leader? But what intrigues me about your story is I find it fascinating that I think as we kind of get older in the profession, it's like something happens to us. It's like we want to leave a mark, we want to make a difference.
yes,
And I don't think when I look back, I certainly wouldn't have necessarily even thought about that when I was a young early career nurse. I would just be, coming in, doing my work, not kind of really wanting to be on the radar for anything else. I loved my job, but I think over time, it's like something happens. It's like we suddenly become aware, actually, there's something we're supposed to be doing here that affects the people who are coming up before, well, not before us, after us. And I think you articulate that so well, because the other thing I want to say, you've studied a huge amount in a very short space of time, and that in itself is a huge achievement.
Well, it's been sort of a mission, when we, and I think part of this too is, as this was happening, I'm watching my new graduate nurses, and we're doing such a good job educating and training them and preparing them. And then, there's that chasm into that first year into practice, the transition to practice year. It's traumatic of itself. And my own daughter was preparing for nursing school and going through nursing school when I was researching and writing this book. And even though she was living under my roof, with me as her coach and mentor. And we hired for her a transition to practice nurse coach to really,
Yeah.
so she would be so richly supported as best as we could do for her. So she wouldn't become another statistic. And sure enough, within 5 months, she was burned out and ready, questioning why she was there. They overworked her like 60, 70 hours a week. It was, it was so
And
I think, that's part of your why too, when you have your
yeah,
child, in this situation. I think you really dig in even deeper than
yeah,
you would just
yeah, yeah,
as a professional curiosity.
yeah,
And yeah, so there, yeah, and I think all of that too was very aligned with what my life purpose and what I was
yeah,
supposed to be doing in these ways at this time. I feel like this, I'm on my Dharma right now.
yeah. Laurie, I want to just touch a bit more on the burnout because I think when I first came across and we first met, I haven't heard anybody else connecting the burnout and the traumatization. And we hear a lot about burnout. It's one of those, I think, phrases that sadly people sometimes talk about burnout, but it's not burnout in the truest sense. So that's one issue. And then I think the other issue is burnout is very real in the helping professions, particularly in nursing. But what I haven't heard is the link to traumatization. And I want to unpick that a little bit more because I know you've done a lot of work around that.
Yes.
And what you found, what was it that kind of you drew from all of that research that you did?
Well, the first thing was I took a look at the burnout, and it was defined in 1970, burnout syndrome.
Yeah, yeah,
Long before we had a trauma-informed culture,
yeah,
globally, right? So there's been no material updates to the burnout literature. And then you look at how the World Health Organization defines it, which sort of, I'm just going to be very direct, pisses me off.
yeah,
Because it's gaslighting. It's
yeah.
defined as occupational stress that isn't effectively managed. That's
I know.
blaming the victim.
Yeah,
And so then whenever a good nurse gets mad, and then when a good nurse scientist gets mad, we start digging, right?
yeah,
And
yeah,
so I started really looking, and that's when I went out of discipline, because it was the same old regurgitated narrative
mm,
that places places the burden, the blame on
mm,
nurses. You need
mm,
to do more self-care. You need to work on your resilience, and does not consider the organizational or system factors,
no,
right? And so then I started looking at the symptom clusters for trauma and burnout. And that's when I started going out of discipline and over into neurophysiology and relational neuroscience, because I wanted to know what is going on in the organism, what is happening in the physiology.
mm,
And that is when I encountered the work of Dr. Stephen Porges, who brought forth polyvagal theory, which
mm,
talks a lot about that. And we can unpack for the listeners if that's something that's of interest. But it really started to explain why I was seeing such an overlap. Now on the surface, they'll say, oh, it's just, you're fatigued, and you're feeling negative about your role. Like, that's the surface
yeah,
narrative, right? Again, with some implicit social structures that keep nurses oppressed
yeah,
and silent and subordinate in their roles. And I just won't have it, not on my watch. i'm
yeah,
i am too old for that. You know? So then I started going into relational neuroscience,
mm,
and really looking there to see, how the burnout narrative is that we should all go home, lick our wounds, go to the back of our cave, light a fire, light a candle, suck, and
yeah,
then the next day, suck it up, buttercup,
yeah,
dissociate, and come
yeah,
back to work. And and I was looking, well, why don't we have like communities? Because, we are hardwired, we're social beings. And so we're hardwired, evolutionarily speaking, in our nervous systems to co-heal and co-regulate. And why isn't that happening? Right? Because we
Mm.
know. And so I started looking at all of this. And that's when I started writing my book, which is called Nursing Our Healer's Heart. And everybody expected me to write a textbook.
Yeah.
That's what is expected of a university professor. But I wasn't interested in writing something for academia. I wanted something to get into the living rooms of my colleagues worldwide that would
Mm.
help to, because we are not getting the education we need
No.
around the language of our nervous system, how
Yeah.
to manage from a trauma-informed lens, how to navigate the trauma exposures that we endure. Now, some of those we get training for. And
Mm.
this is when, like, this was another huge divine gift. It all but parted the Red Sea in my world. As I'm writing this book, in my inbox, because I was looking, part of being a nurse scholar is being very well versed in the philosophy and theoretical underpinnings. I'm just getting all
Yeah.
my geek flags out now. I'm just going to wave them all right now. And so I was looking for a theoretical foundation to ground my work in, because I knew I was onto something.
Mm.
And I knew that if I tried to apply for grants or tried to put it through peer-reviewed journals, it was going to get whitewashed. I knew this to be true. I could feel it in every cell of my body. It's like this has to get directly to the nurses.
Mm.
And so one day in my inbox landed, because I thought I was going to write the middle range theory for nurse psychological trauma, because we didn't have one. And
No.
Dr. Karen Foley at Purdue University published it. And it was like, are you kidding me? Like, this
No.
is this beauty of synchronicity.
Yeah.
And even though she and I have never met, we're studying this, we're researching in the
Same
same,
thing. Yeah.
we're on each other's email list somewhere, or, and so this middle range theory, oh, I see, I just get goosebumps, my whole body when I even remember that day, because it was like, this is now nurses have something. We can take this middle range theory, we can take my science that I have packaged in a very first person friendly nurse coaching way, as though you and I are chatting right
Yeah.
now. It's not a textbook for all of you who are still traumatized from
No.
nursing school. That's not what we're doing here.
No.
And so, but we have this middle range theory now that nurses can take into their employers, to their leaders, and say, this is what is happening. And here's Dr. Lorre's research. And this is and let us rethink this burnout thing. Let
Yeah.
us rethink professional well-being. Let us rethink how we are not keeping nurses safe, even from the perspective of their autonomic nervous system.
Yeah.
So
I
if
find
nurses
that
aren't safe in practice, then we're not well.
I find that fascinating, Laurie, because what that's essentially done is move the narrative away from it's us, our self-care, you just have to go away and do all those things you've mentioned, to putting it back very squarely, almost as an occupational hazard, which changes the whole dynamic because,
Yes.
from a health and safety perspective, that's a big shift. That's saying, the workplace and the environment and the pressures are causing nurse traumatization, and therefore an organization has a responsibility to address that. And that's a really powerful shift in the whole, burnout self-care conversation, isn't
Right.
it? It's just,
Well, yes. And then, here's the thing that's so important is that a person cannot self-care themselves out of trauma.
no,
It
no,
is helpful. It is
yeah,
helpful. It has its place. I don't use the word self-care in my work, nor do I use the word resilience, because the
no,
thousands of nurses that I've worked with across the globe, feel gaslit by those terms.
Yeah.
And so I use nurturing and nourishing ourselves.
Yeah.
And, you know, Dr. Foley, in her middle range theory, she brilliantly made it very clear what was avoidable and unavoidable. And
Yeah.
so we have, with our profession, we do have some unavoidable trauma exposure that we do get some training on in nursing school and in our in-service, and you know, because we do have vicarious and secondary trauma exposure. That's part of the job.
Yeah.
And we also have trauma from disasters, right? That we've been trained if there's
Yeah.
a major flood or an earthquake
Yeah.
or, you know, catastrophic air accident, you know,
Yeah.
airplane crash, you know, we all know how to, we might be a little rusty, but we but we know how
Yeah.
to
Yeah.
respond to those things. But that's not the problem. That
No,
is
it's
not what is driving nurses from their profession in
mm,
droves. To quote Dr. Terence Hill, who is a medical sociology of the highest sociologist of the highest regard, he says the world is hemorrhaging nurses right now.
yeah, that's so true.
And he's not wrong. So it is the avoidable nurse-specific trauma exposure that
Mm,
is driving nurses from the profession, and for very sound physiological reasons.
yeah.
So we have, you know, we have the workplace violence, and that it just every year the statistics are the violence, the physical violence,
Yeah.
verbal, emotional, the lateral violence, the workplace incivilities,
Yeah.
right? That's avoidable. We have the legacies of generational nurse trauma that are being transmitted unknowingly from one generation of nurses to the next.
Yeah.
And that's best captured by that phrase, nurses eat their young.
Yeah. Yeah.
Right.
Yeah.
So that's avoidable, but people don't understand that that is unintegrated trauma at the collective level that is being transmitted. So we can do something about that.
Mm.
Insufficient resources, having dangerous staffing ratios. Like there's no new grad that should have 6 or 7 patients
No. No.
ever.
No.
And we shouldn't be floated to units where we don't have any specialty.
No.
You know, every nurse comes out a generalist and then becomes a specialist in their field because healthcare delivery is so complex. So, you know, if you're working in ICU, you might be challenged over here at the transplant unit where things are, you know, or the oncology unit, because each of those are very, very specialized care delivery models, and the list goes on. And so what we have also, a big one, is where it's called system-induced trauma. And that's where the system itself is inflicting the trauma. And a brilliant example of that is nurses like myself, and I would imagine that there are many in your audience that, like me, have been
Yeah.
hit, kicked, spat upon, hair pulled,
Yeah.
bruised, battered,
Yeah.
verbally abused, and had bodily excrement thrown at us. And then you go and report that according to your unit and your company's policies. And the first question you're asked is, what could you have done differently to prevent this?
It's interesting, Laurie, because Australia also has high numbers of workplace violence.
Yes.
Of, you know, increasingly, particularly if you're working in a frontline department like ED, but also dealing with those issues in a ward situation. And whilst the stats are collected, we have to report those as incidents. You know, what really interests me is we, as a profession, so if I take Australia as a nursing profession, there is no requirement here for clinical supervision. And I know clinical supervision isn't the be all and end all, but it's one aspect of somewhere where you can go and have a conversation about something that's really affected you or you found really challenging to deal with, with someone who's trained, and we don't have that here. So if we look at the psychology profession, it's a requirement for their registration.
Yeah.
And I find that
Yes.
fascinating, that if you look at the workforce in health, nurses are the largest proportion of that workforce. I suspect one of the reasons why is cost, because it would cost a lot of money if we had to start putting in some of these things. You know, sadly, I think that's possibly a factor, but it's like we're putting a band-aid on this and no one's
Yes.
listening. And people are leaving, nurses are leaving, and like you say, we're hemorrhaging nurses. So where are we going? What are we going to be left with? We know the numbers of nurses coming into nursing have dropped significantly post-COVID. I also know from experience here that we're not keeping our grad nurses. You know, they're leaving. They do a short period of time. They either leave altogether or they're kind of splitting, having part-time hours in a hospital and part-time hours, to use their words, doing something less stressful, which again is interesting because there's a whole shift in working patterns happening outside of organizations by choice. And I think precisely for these reasons. So I'm curious to know, Lorre, where kind of, because I know that spirituality is something that you're really passionate about. And again, it's a topic that we don't really talk about a lot in the profession. It's, you know, and a theory on that for me is we're in the push to become a profession that's scientific and rational and logical. We don't go there and we don't acknowledge those important parts of the spiritual work that nurses do, and yet it's a hugely important component. And I'd like just to invite you to share your perspective on, you know, spirituality and the work that you do, because I know you do a lot in that space.
Yes. Well, back to your, about the money and the hemorrhaging nursing, and this is, it's connected to the spirituality, is that we have, as a society, as Western developed medical systems and health delivery systems, we have lost sight of the whole person.
Yeah.
Right. Now that includes the people who are providing the care, including nurses,
Yeah.
and that includes the patients. And you can't put a lot of things on a spreadsheet, right?
No.
There are quantitative things. I can count the number of bandages and the number of IV bags and so forth. I can count those, and I can put those. I can count the number of hours that anyone works in a week, right? So there's a lot of things that we can be quantified, and we have become skewed in the
Yes.
quantitative at the expense of the qualitative, integrative, or whole person approach to healing, which includes those who are providing the care. Right. So that's the biggest issue, is that we have gotten everything down to computers and to barcodes, and yes, technology has a place. It is to aid clinical processes. It is to assist with administrative burden. But we have, and for lack of better terms, we have given away our empowerment to the technology. And to the system. Yeah.
So true, because if you think, if I think back to my training, that's how we were trained. We were trained to look at the whole person-centered care. I can remember that being.
And still are. I mean, that's still central.
Absolutely.
Yes.
And yet.
And rightfully so.
Yeah. And yet we've reduced so much of what we do into that whole data collection and filling in forms. And I think what that has done is eroded the time that we have to spend to look at the whole person, even down to, the spirituality component of assessing somebody. That's not done particularly well, because when you're pushed for time, you do the bare minimum, and that's that. My experience of that has been it's left
Yeah, you
to
do
the side.
the focused assessment.
Yeah,
Everybody does
yeah,
a focused assessment now. Very
yeah,
few people are doing. And this is part of the existential crisis that our early career nurses and our new graduates have, because we teach them the right way, the way
yeah,
that it should be done, right? And then they go into a system that has other priorities.
yeah,
And so what I've had the new graduates, of which I've more than I can count at this point, and nurses that I've worked with also probably more than I can count, although I have a tally somewhere, it's in the thousands.
yeah,
Um, and so it is, it's described to me because I've asked. It's like, well, it's like your healer's heart, your why for nursing, your
yeah.
why. It doesn't have to be a calling for everyone. For
No,
many it is, but it doesn't have to be. It's a wonderful profession, and if that's something that you would like to do and it's not your calling, as equally important as someone like myself who has a very clear
yeah,
calling, right?
yeah,
So I don't want to minimize anybody's contributions. But so for whatever the reason, we all have our why, whatever that might be, right?
yeah,
Different for each of us. And so I started asking our early career nurses and our new graduates and about that, and using the term healer's heart, because that's really where the patient-centered care comes from. And that
yes,
when you look at it through the lens of trauma and polyvagal theory, it's not available to nurses who are in flight or flight, in their sympathetic, or in what I call sympathetic overdrive, or they're in kind of this shutdown because the stress and trauma exposure has been too great for so long. It's called the freeze. And so then our heart-centered, patient-centered care, it isn't even physiologically available to us. And so asking these nurses, what do they think about this? And what's their experience? And two prevailing themes emerged.
mm.
Because that's what I do for a living, is look at themes. And it was, my healer's heart has been run over by a steamroller, or it has been put through the paper shredder.
Yeah,
Now,
that's so
those are
sad.
some pretty graphic, deep terms, that this is how so many nurses are feeling.
Mm,
And then we are, continually asked to do more with less, and endure more and more trauma exposure. 86% of nurses who are among the high risk
mm,
professions for trauma exposure, right up there with military, combat personnel, law enforcement personnel, first responders, nurses, right up
mm,
there in that top tier of first responders who have a lot of trauma exposure. 86% of nurses have little to no resources or support
yeah.
in navigating that. And so the narrative is, well, you just need to go, get a manicure, you'll be fine. Excuse me, please stop with that.
Yeah,
Please just
yeah,
stop. And so this is where, tying that back into spirituality. And while my book is not overtly spiritual, it was spiritually written because I
mm,
wanted it to be accessible for any person of any faith, or lack thereof, whoever and however you are. If you are struggling with burnout symptoms that are not resolving through the usual, what we say, self-carrying them away,
mm,
then chances are very strong that you are experiencing nurse-specific traumatization. So I wrote this book through a spiritual lens, but it is not spiritual because there was a lot of healing codes. I have different abilities that we all do, and I just
yeah,
happen to be connected to mine. I was just born with a little bit extra in that way. And so there's a lot of, as I was writing, I was downloading sacred geometries that were infused into not only the book, but every word that I speak at this point. And so there's a lot of healing energy coming through for the nurses, because it starts with us. You know, part of the reason, if you want to look at it through the lens, okay, of a sociological lens, and then you want to apply some layers of colonization and patriarchies and, lots of oppressive societal structures that are embedded in our in the cultures in which we live and work, from which we are not separate, right?
No.
We are connected to one another in all of these contexts. And so how interesting and how convenient is it that we continue to blame the victim, we can continue to oppress the nurse and tell them that it's their fault. And at the same time, but please keep coming back and do more with less.
Yeah. And I just want to pick up on something you said, Lorre, because when you talked about that freeze state, that, the whole culture, and it's a horrible phrase, but it's an accurate phrase in many ways. The nurses eat their young. When you look at that state and you look at all of those other factors, like the lateral violence, the history, the patriarchy, all of those things, it has sucked the heart out of nursing, and I think it's turned us inward. And again, it's not, you articulate that, connecting those dots so well, yet we don't hear those conversations. We hear bits of the conversation, but we're not really hearing and honoring the history. Because if you look at the history and the fact that nursing remains largely a female dominated profession, that is changing, but changing slowly. There's so much tangled up in this. And I think it's almost the easy out, isn't it, to say, oh, well, it's something you're doing, it's your fault, you're not looking after yourself, you're not doing X, Y, and Z, is the easy out. Right. Because to acknowledge all of these other factors means you actually have to do something about it in a way that stops the hemorrhaging of nurses.
Right. Well, and that's why I took the approach that I did, quite frankly, because I knew if I put it into the system, that's exactly what would happen with this, like everything else that's gone before it, right? I knew that. And so here's where, we're all keenly aware of these problems because we live them every day. And so, here's where really it starts with each of us as nurses, individual nurses, to become aware. We aren't getting, whether it's by design or omission, we aren't getting this education. I just went through with a fine-tooth comb. Here in the US, we have what's called the American Association of Colleges of Nursing, and they set the curriculum, the standards for nursing education, certainly here in this country and in many others, adopt, from this good work. And so I spent 2 days going through it with a fine-tooth comb, the essentials. What are we teaching our students? Are we teaching them, how to, any of the things that we're talking about? And it was the same proclamated narrative of burnout and nurses this and nurses that, and even to the point where it said if nurses felt that they need to come together and perhaps protest within legal boundaries and all, ethical boundaries and all those things, but to voice and advocate for themselves, that it was the nurse's responsibility to find a replacement for them.
Very nice.
I mean, like, how many ways do you want to handcuff, bound, and gag
Yeah,
us as a collective profession?
yeah.
And so here's what we can do. So we can probably all agree. I mean, I've been around 50 years now. A
Mhm.
half of a century later, and wide sweeping system change is slow. Societal change is glacially slow. So I
Yeah.
think we can all agree that the system isn't going to fix itself anytime soon.
No.
Right? I mean, I think we can all come to that conclusion because we've
Sadly,
lived it,
yeah.
some of us for decades. But what we can do, the point of empowerment, the point, and this is where it gets a little spiritual, but it's true. The point of
Mm,
empowerment is always, always within us and always in the present moment.
mm,
So we have a choice to continue to be spoon-fed the burnout gaslighting narrative, and we can accept that as a status quo. It's a choice.
mm,
Or we can get really curious about what's happening behind that burnout narrative.
mm.
And we can take a peek behind that veil and say, wow, this looks a whole lot. Let's study. And it's in my book in a very approachable manner, but like I walk everybody through Dr. Karen Foley's middle range theory, and let's explore that together. And let's see what that looks like in practice. And now here's 100 different strategies. I present a four-step evidence-based framework that can be used by any nurse anytime, and practices that can be done in 30 seconds or less, even if you're responding on your way to respond to a code. Even then, you can do them. And so a lot of this burnout narrative is like you need to go away and take 3 hours or 2 hours or 1 hour. And no, from the perspective of our autonomic nervous system, the most ancient system that we embody that has kept us alive over the millennia, between that, the midbrain, and the vagus nerve,
Mm.
if we partner with the wisdom
Yeah,
of our physiological structures that innervate nearly everything, if not
yeah,
everything, right? And we partner with that wisdom when we learn the language of our nervous system. And when I say nervous system, I mean autonomic, but it's a mouthful to
yeah.
say. But we partner with that, and we learn
Yeah.
polyvagal theory, and learn how to self-assess where we are in a particular nervous system state. And then we can nourish our nervous system with what it needs, because
Mm.
Stephen Porges coined this term. It's called the threat detector. And
Mm.
it's this process in the midbrain that has one job, and that is to keep us safe.
Yeah.
Always surveying for cues of danger in our environment, and also, where it starts to get a little juicy, in our inner landscape.
Mm.
Because what trauma didn't get fully healed at the time it happened, which is the vast majority of it, it gets stored in the body.
Yeah.
It
Yeah.
gets stored in the skin, the muscles,
Yeah.
the fascia, and the neuroplexes.
And then
And
it has
so look,
a physical component, doesn't it? Because that's the other thing.
very, very
This.
physical. Yeah. And so we learn how that works, and then we can start insulating ourselves from the effects
Mm.
of the trauma exposures, because we can't wait for the system to do this for us.
No.
We have 86% of nurses who say, I got nothing.
Yeah.
So
Yeah.
here's something. Here's something
Yeah.
now. Here's
Yeah.
something. And I'm
Yeah.
not saying that, I'm solving world peace or I'm solving the nursing crisis here. But what I am saying is that I did do the 5 years of research. I
Yeah.
self-funded it. I'm 6 years and six figures into this research now. And and bringing the book out globally to help any nurse who with whom this work resonates. Like,
Yeah.
if and we start there. And then what I found is that, well, one nurse tries it and they like, oh,
Mm.
I this is, and then they tell their other work friend and their other work friend, and then before you know it, we have what I call Halen nurses, which is Halen is the old English word for healing. So that means we have taken responsibility, personal responsibility for that which has happened to us. And we are getting in the driver's seat instead of being in the victim seat and saying, we're going to learn how to do this, and we're going to come together as communities. And so I call that Halen Nurse communities, where we are healing together in community as is evolutionarily designed. And then when we start doing that, then we can start co-regulating in practice together. And so now we are creating this insulated network. The system hasn't changed.
No.
Right? We're not waiting.
No.
We found another way. And then the ripple effects start going. And then it's like, oh, well, this whole unit is doing this. And, can I come do an in-service? And can we do a retreat? And yes, and yes to all of those things.
Yeah.
And this is how we start to reclaim our empowerment back from the system that would otherwise keep us marginalized, minimized, oppressed, and disenfranchised from the decision-making table where we rightfully belong as 50% of the global workforce for healthcare.
It's so funny. We've got so many similarities in our approaches, Lorre, because you know the work that I do, and that's, it's coming at it from another angle because you can't actually get the inroads in other ways. And I just, that whole ripple effect, that's what I talk about in leadership too. You give somebody the skills to help them, very practical how to, and they pass those on to someone else. And then that's where we grow this community. And I think for you, that's a hugely important piece of work because, we need nurses to know how to do this because there isn't anything that's really doing that. And your research is fundamental to that.
Well, this is how we transcend nurses eating their own. This is the antidote to that. And it bears mentioning, since you did bring in leadership, which is so important. The last chapter of the book is just that. It's providing some road mapping. Now, I'm not saying solutions, but approaches to start having these difficult conversations with our leaders, among us ourselves as leaders, and reframing, taking an integrative, trauma-informed approach to patient care, right? That involves keeping the nurse safe.
Yeah.
Right, for us to do our job. We can't do patient-centered care if our autonomic nervous system has in flight or flight. It's not physiologically available. And then how we can also continue to how we can shift as nurses to prioritize our own professional well-being and what that. So there's 3 sets of integrative nursing principles. I drew from the seminal principles from the integrative nurse scholars, Kreitzer and Koithon. And then I added 2 more. Is like, these are the integrative nursing principles for nurse professional well-being. And here's 6 principles that can guide those conversations. And then here are 6 integrative nursing principles that can guide leadership. And as us coming together, my vision, my big vision, my big prayer for our profession is that we come together as a global community and we start working from our healing scars instead of our gaping wounds. And we usher in nursing 2.0, which is the nurse safety and professional well-being edition. Because we are the linchpin of care. And if the system's not going to do it, we have a lifetime, we have decades, centuries of evidence that is, highly unlikely to happen. But we always, in the present moment, that is the place of empowerment. And it starts with us healing individually and collectively and coming together, like, the network effect. and we
Yeah.
get these different nodes, and that's why my work is international. I'm talking with nurses in Australia and in Europe and in
Yeah.
Canada, and
Yeah.
anyone who would like to have a conversation with me.
It's fascinating, Laurie. I almost feel we need a part two podcast to go into some of these things in a bit more
We should.
detail, because I honestly think, I would love to give you the platform just to give some practical, we've
Yes.
talked a lot about the leading research on this topic, and you've talked about polyvagal theory, and I think it would be really good just to have a practical session that just gives people this is how you do it, because the more people know about the work you've done and your book, the bigger the reach. So I think that's something we really do need to consider. So the focus would be on that. But one of the last things that I want to ask you, Lorre, is, has there been a lot of interest in delivering kind of training and sharing the work that you've done globally?
Well, yeah, we're just getting started. So the book is being released, within within 6 weeks or so.
Wow.
And
Oh,
so,
that's
so
great.
that's and so what, and I thought I was done, just like when I
Yeah,
thought I was done with a
yeah.
PhD,
Oh
and then
no, never
no,
done.
you're writing this book, and then I finished the book, and I'm like, well, surely I must be done. And oh, no, 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 you're not done yet.
Oh,
And so that led me to start a nonprofit organization,
yeah.
and it's called the Halen Academy. Again, the Healing Academy, but I love that old English word.
Yeah,
I
that's a
hope one
great
of
word.
I hope one of my children name of their child Halen. That's how obsessed I am with that word, but that might be a bridge too far. But and through that nonprofit organization, we do offer nurse trauma healing programs that are specific for nurses.
Yeah,
And we are just getting that going. We've completed our first cohort, and we're moving it over to a new learner management system, but it is ready to go. We can receive anyone who is ready. And then I well, not, it's not odd, but surprisingly, because I wasn't, my little limited human mind wasn't going in that direction, but we have had an equal amount of interest and requests for trauma healing for anyone. Like,
yeah.
I'm not a nurse, but I have trauma and I
No,
don't know where to start.
yeah,
And
yeah,
so we are going to be launching that within the next month,
yeah,
and plans are already underway. So, um, everybody on the planet
yeah,
has been touched by
yeah,
trauma, and most of us have not fully healed, and it's just hanging out in the body, and there's so many other things that we can talk about. There's,
yeah.
how it affects our mitochondria, and how the mitochondria dysfunction leads to a host of chronic health conditions, again, that we're not being taught about in nursing
No,
school.
no.
And part of it is because, we can't know everything. I get that. This was going kind of
Yeah,
far out there, but I think at minimum, we should know polyvagal theory, and we should understand what
yeah,
nurse-specific
absolutely.
trauma is,
Yeah,
and how
yeah,
to protect ourselves.
yeah, yeah,
So yeah,
absolutely.
so the interest is coming, and in the interim, I do have a YouTube channel, and so there is content, and I have a podcast that's also on my website. Everything's on my website. So if anybody just wants to, like, not want to wait, not want to wait to get the book, don't want to wait for me to come back and spend more time with you, which I'm happy to do, then
Yeah,
there is content out there, and the
yeah,
Academy is ready to receive anyone. It's a 12-week program.
yeah,
And most burnout programs, and I'll just kind of close it with this, most burnout programs, and I looked around the world, because that's what I do,
yeah,
and they post a bunch of resources. It's just an extension of the gaslighting narrative. They
mm,
post a bunch of resources on a website and essentially say, nurses, go heal yourself.
yeah.
That is not how healing works, because
No,
if it were, we wouldn't be needed.
no. So
We
true.
wouldn't give a cancer patient a bucket of chemo,
No,
drugs, and adjuvants, and say, go heal yourself.
no,
Healing we can
Yeah.
get some healing is introspective, but the
Yeah.
vast majority of healing needs to be facilitated, particularly when it comes to trauma healing.
Yeah.
And so that's why I am, like, every week I am the guide and mentor, and I bring other experts into the container too, so that we're not just asking nurses to, go heal yourself after after all that you've endured.
Oh, Lorre, it's been such a pleasure today. Honestly, I feel like we've just scratched the surface. I think there's so much
We did.
more, to this work and the dedication to that work, because, I've done a little bit of studying, not on the same level as you, but I know how much it takes to do that. And I think credit to you. And I also want to say thank you, because you're passionate about this. You've invested time and energy, and you have a mission to make this knowledge accessible and to the nursing profession. And that's a really important why. And I, as a nurse, one nurse to another nurse, I just want to say thank you to you, because, that's such an important thing. Oh, it's not even a thing, that's not the right word, but it's an important mission to have, for the benefit of all of us globally, not just, in America, but it touches every part of the planet. And I think, yeah, it's very much needed, and it makes my heart sing to think, that we're working in a space where we're trying to put some of that heart-centeredness back into the profession that we've lost along the generations. And I think that's hugely important. So I will put all the links to your book and your podcast and your academy in the show notes. So if people listening do want to know more, that we can signpost them to you. And we'll leave it there for now, but I think we definitely need a part 2, Lorre.
I know. I was just gonna, like, quote one of those
Yeah,
Arnold
sure.
Schwarzenegger
Yeah.
movies, like, "I'll be back." I'll be back.
You will. I have no doubt about that, Lorre. So thank you so much for your time
Thank
today.
you.